Welcome back to our channel, guys. My name is Noel, and in this video I'm just going to take you through a quick tutorial on the glenohumeral joint, which is also known as the shoulder joint. This is a synovial ball and socket joint, and it is an articulation between one third of the head of the humerus with the pear-shaped glenoid fossa or glenoid cavity on the scapula. This is in contrast with the hip joint, where two-thirds of the head of the femur take place in the articulation with the pelvic bone. The important thing to know about this is that the shoulder joint has a wider range of movement, but it is less stable and more prone to dislocations as compared to the hip joint, which is more stable, less prone to dislocations, even though it has a narrower range of movement. But we will talk more on the hip joint in the next videos. So back to the shoulder joint. The shoulder joint is surrounded by a capsule which is medially attached to the margins of the glenoid fossa or glenoid cavity on the scapula, and laterally it is attached to the anatomical neck of the humerus. The capsule itself is covered by the synovial membrane, which is attached to the margins of the hyaline cartilage covering the articular surfaces. So there are two important things to know about the synovial membrane, and the first thing is that it forms a tubular sheath around the tendon of the long head of the biceps brachii muscle, and secondly it passes through the capsule and emerges as the subscapularis base beneath the subscapularis muscle. So now we're going to move on to ligaments and muscles that strengthen this joint. So we have four muscles which you can easily remember using the mnemonic STI, and these muscles are known as the rotator cuff muscles, and these are the subscapularis muscle, the teres minor muscle, the infraspinatus muscle, as well as the supraspinatus muscle. So we have three main ligaments that support this joint, as well as an accessory ligament. So the three main ligaments that we have are the glenohumeral ligament, which supports the anterior aspect or the front of the capsule. We also have the transverse ligament, which bridges the gap between the two tuberosities and holds the tendon of the long head of the biceps brachii muscle in place. We also have the coracohumeral ligament, which strengthens the capsule from above. And now our accessory ligament is known as the coracoacromial ligament. According to as you can see from its name, it extends from the coracoid process to the acromion, and this accessory ligament strengthens the superior aspect of the capsule. We're now going to move on to innervation. So two nerves innervate this joint, and these are the axillary nerve and the suprascapular nerve. We're now going to move on to movement. So these there are seven different movements that occur at the shoulder joint, and these are flexion, which is 90 degrees. Normal flexion is 90 degrees at the shoulder joint. You also have extension, and normal extension is 45 degrees at the shoulder joint. You also have AB abduction and AD adduction. You also have medial rotation. You also have lateral rotation, as well as circumduction. Circumduction is a combination of all these movements that we talked before. And an important thing to note about abduction is that two muscles uh, they work together to perform abduction, and these are the deltoid muscle and the supraspinatus muscle. So the supraspinatus muscle initiates the movement, and the deltoid muscle finishes the movement. What I'm saying is that the supraspinatus holds the head of the humerus against the glenoid fossa, and then the deltoid muscle contracts and abducts the humerus. So that is very important to know. Now we're going to move on to relations. So we're going to talk about structures that are related to the to the glenohumeral joint. So we have structures that are related anteriorly. So we're talking about structures that pass anterior to the joint, and these are the brachial plexus as well as the axillary vessels. And we have structures that pass inferior to the joint, and these are the axillary nerve and the posterior circumflex humeral vessels. Maybe another important lesson that you should note is that the tendon of the long head or the bicep brachii muscle passes through the joint and emerges beneath the transverse humeral ligament. So this is something that you should just note. It is usually act in MCQ questions. So finally, to close up this video, we're going to talk about clinicals. So two main dislocations happen at the glenohumeral joint. We have the anterior inferior dislocation, which are more common, and we also have the posterior dislocations, which are very rare. So the during the anterior inferior dislocations, which we say are more common, which is they're common because the inferior part of the capsule is less supported as compared to the rest of the joint. So the inferior part of the joint capsule is the weakest part of the joint. And in this dislocation, the head of the humerus is displaced forward and upward. So the head of the humerus moves interior and then upward. And on the posterior dislocations, which are very rare and are usually due to direct violence or direct trauma to the front of the joint, during this dislocation, the humerus is displaced downwards, which may result in damage to the axillary nerve as well as damage to the radial nerve. And if the axillary nerve is damaged, it may result in paralysis of the deltoid muscle, which results in the inability to abduct the arm. As we say that the deltoid muscle abducts the arm in working together with the supraspinatus. So if we damage the radial nerve now, it may result in conditions such as wrist drop. We will talk more in detail about wrist drop as well as any other clinicals related to damage of these nerves in our following videos. So to close up this, I'm just going to do a revision. So I'm just going to leave an MCQ question and give you guys just 10 to 15 seconds to answer it, and then I'll give you the answers. Okay, guys, so I guess some of you got the answers correctly and some of you got it wrong. But you can always rewatch the video so that you get to know which parts you missed and just to revise and pick up some of the parts that you overlooked or overheard when you first attempted to hear this video. So that's it, guys. Remember to like, subscribe, and turn on the notifications so that you do not miss out on the next tutorials that we are going to be posting. Cheers.